Hello everyone. Today I am going to start with topic zygomaticomaxillary fracture. ZMC refers to the skeletal unit formed by the zygomatic bone and maxilla. These two bones are referred to as a complex because of structural and functional relationship between them. They articulate with each other over a wider area, and any traumatic impact on one bone generally influences the other. The zygoma articulate with four bones through five processes. These are superiorly frontal bone, medially maxilla bone, laterally temporal bone, posteriorly sphenoid bone. And these processes are zygomaticotemporal, zygomaticomaxillary, infraorbital process, frontal zygomatic process, zygomatic process. What is classification? Classification by Rowe and William based on axis of rotation of ZMC following trauma. The zygoma may undergo rotation along two axes. One is vertical axis extending through the zygomatic suture and first molar. Horizontal axis running across infraorbital foramen and zygomatic arch. On the basis of stability, fracture which are stable after arch elevation, arch only fracture with medial displacement and rotation around vertical axis. Fracture which are unstable after arch elevator, arch only fracture with inferior displacement, zygomaticomaxillary fracture rotated around horizontal axis. On the basis of rotation of ZMC along vertical axis, line through frontozygomatic region and first molar. Along horizontally, line passes through infraorbital foramen and zygomatic area. What are the clinical features of zygomaticomaxillary fracture? Facial asymmetry, periorbital edema, hematoma, emphysema, facial asymmetry due to malposition zygoma, which leads to the depression of the molar prominence, orbital dystropia, which means bony orbit is displaced. Discoloration due to conjunctival hemorrhage and periorbital ecchymosis. Eye sign, it means hypoglobus. Eyeball is displaced downward in the orbit. Mongoloid slant of the eye, it means lowering of the lower eyelid. That means it increases eclateral flow. Occlusal epistaxis, tenderness on digital palpation, step deformity at frontozygomatic buttresses. Air emphysema, when there is a fracture through sinus wall and which allow air escape into facial soft tissue. Diplopia, it means double vision. Restricted mouth opening due to fracture of zygomatic arch impinging on temporalis muscle causing spasm. Paresthesia, inferior orbital nerve close to the zygoma which gets compressed leading to the paresthesia along the lower eyelid, upper lip and lateral aspect of nose. What are the radiographic imaging? Waters view, submentovertex view and CT scan. Now we are going to discuss with management of ZMC fracture. First is surgical objectives. Restoration of facial aesthetic. Then restoration of premorbid ocular function. Then restoration of premorbid central function. Then prevention of exophthalmos. What is the reduction of ZMC fracture? There are indirect reduction and direct reduction. The fractured in indirect reduction, the fractured zygoma is reduced without directly exposing fracture site. It means Gillis temporal approach. In Gillis temporal approach, an incision is made through temporalis fascia to reveal underlying temporalis muscle. A Howard elevator is inserted between the temporalis fascia and muscle to create plane of zygomatic elevator. This zygomatic crystal elevator is positioned in the plane created directly inferiorly to reach deeper surface of the zygoma and carefully elevated while on ironing motion is used. In direct reduction, the fracture site surgically exposed and zygomatic bone is reduced under direct vision. Next part is incision to assess ZMC fracture. First, we have to give a lateral eyebrow incision which offers a fast and direct access to the frontozygomatic suture and lateral part of supraorbital rim. Next one is subciliary incision, which offers good exposure of infraorbital rim along with the entire orbital floor. The skin is placed along the entire length of the lower eyelid 2 mm below the level of eyelashes. The level of eyelashes to conceal the future scar. Next one is subtarsal incision. It is a mid-lesion incision is marked 5 to 7 mm below the inferior lid margin corresponding to the lower border of the tarsal plate along the subtarsal crease. Next one is vestibular incision. The vestibular incision is the most frequently approach to assess zygomatic buttresses. The popularity is due to its application for reduction of ZMC fracture as well as fixation at the ZM buttresses. What are the fixation methods? First one is rigid internal fixation. Second one is non-rigid internal fixation. And what are these fixation points? First one is one-point fixation, refer to the fixation at either frontozygomatic or zygomatic suture. This has been found to be adequate in resisting post-reduction instability in simple tripod fracture while reducing hardware and surgical exposure. Second one is two-point fixation, which indicates fixation at zygomatic buttresses, frontozygomatic suture and infraorbital rim. Third one is point fixation is also called tripod. It includes fixation at frontozygomatic and zygomaticomaxillary plus infraorbital rim. Fourth one is all 3 point including frontozygomatic, zygomaticomaxillary, infraorbital rim, along with them zygomatic arch. Fifth point fixation is phenozygomatic suture is also fixed in addition to these 4 sites of fixation. Zygomatic buttresses located at maxillary vestibule, which helps to restore and support of midface. Plate fixation is done here.